Welcome, everybody, and thank you for joining our web seminar. My name is Katie Vollrath. I'm the TCD Clinical Specialist with Natus Neurology. Today's topic is performance of the TCD exam with special tips and tricks. I'm pleased to be hosting today's session in conjunction with our education team. In a moment, I'm going to introduce you to our speaker and presenter and more. But first, I want to go over a few housekeeping items. Today's session is being broadcast across the Internet, which means the presentation can be heard through your Internet speakers. I'm also joined today by my colleague, Bob Martin, who is listed as the host in your WebEx panel. Please feel free to send him any questions if you have technical issues. During the presentation, please write down any questions as you're listening to Ann, and go ahead and submit them using the WebEx chat box to either myself or the WebEx host. And then at the end of the session, we'll give you another opportunity to submit questions. I'll be moderating all of the questions at the end of the session after a brief pause. So let's introduce today's speaker, Ann Moore. Ann has been active in the vascular field since 1984 and has worked at Harborview Medical Center in Seattle since 1994. Currently, she is the Cerebral Vascular Laboratory Supervisor at Harborview. Ann has a plethora of TCD experience in a wide variety of pathologies and has contributed to many scientific publications about TCD and other vascular ultrasound applications. We welcome Ann today and look forward to her insight as a very experienced technologist and educator on perfecting the performance of TCD exams. Ann, I will turn this over to you now.
Thank you, Katie, and thank you for inviting me. I'm not seeing my slides. There, thank you. I'm going to talk today about the performance of a normal transcranial Doppler examination and hopefully give you some tips and tricks. A little bit of history. Dr. Rune Oslet, back in 1982, founded TCD. He was sitting in his basement with a duplex machine. He placed the probe on the side of his head and found intracranial flow. He was the first to publish normal values for the anterior circulation. Back in 1983, Merrill Spencer, here of Seattle, perfected the transorbital approach, and Arnold and von Ruyden in 1986 perfected the transoccipital approach. And it wasn't until 1990 that a German neurologist developed transcranial imaging. I just want to go over a little bit of anatomy. Transcranial Doppler can insonate the vessels of the circle of Willis, which you can see here in the middle of the screen. And the circle is comprised of the anterior communicating artery, the ACAs, or the anterior cerebral arteries, the bilateral internal carotid arteries, the bilateral posterior communicating arteries, and the bilateral posterior cerebral arteries. However, the middle cerebral arteries and the vertebral arteries and the basilar artery are not part of the circle of Willis. The ACOM joins the right and left brain, and as you can see, the A2 segments, which are beyond the ACOM, cannot be insonated by TCD because of the angle of the vessels. Here we see the middle cerebral artery, M1 branch, divides and becomes M2 branches. Usually, transcranial Doppler can pick up only one of these branches, and then the other branch, if there's a stenosis or vasospasm, that pathology could be missed. The posterior communicating arteries join the anterior circulation with the posterior circulation. And the bilateral vertebral arteries join to form the basilar artery. Sometimes when we're insonating the vertebral artery, we see this posterior inferior cerebellar artery. but usually it's not traceable. And keep in mind, all of these arteries have little branches coming off of them. And it's not shown here, but even on the communicating arteries, there are branches. Now, the internal carotid artery has multiple segments. The extracranial internal carotid is insinuated through the submandibular approach. The petrous segment is where the ICA enters the skull. The petrous, the lucernum, the proximal cavernous, and mid-cavernous are not insinuated by transcranial Doppler. Over the eye, we can insinuate the distal cavernous, the clinoid, and the supraclinoid ICA. Here in this violet area is the terminal ICA, which is insinuated through the transtemporal approach. And this is where the internal carotid divides into the middle cerebral artery and anterior cerebral artery. Now, we identify the intracranial vessels based on the location or windows, and we also call them approaches. The depth and directionality of the waveform. We use a 2 megahertz pulsed wave Doppler. Velocities are reported as time average mean in centimeters per second. And here is a picture of a skull illuminated with a light. And you can see the thin area of the transtemporal bone compared to the rest of the cranium. And this is why we can insinuate through the transtemporal approach. When I say transcranial Doppler, I'm talking about the non-imaging technique. And this is an example of a right middle cerebral artery at a depth of 50. And on this diagram, it's probably going to be about here. Flow is coming towards the probe and is above baseline. And baseline is delineated by the 0 on the scale on the left side of the waveform. And we can see that it's a normal velocity, it's 49.7, and the pulsatility is 0.97. Now, if we increase the depth of the beam of ultrasound to 58, now we're seeing flow below baseline. And that is at this point. This is the anterior cerebral artery. Now, about 10% of patients have hyperestosis, which means that the bone is just too thick for the ultrasound to go and penetrate through. We see this especially in older Caucasian females, Asians, Native Americans, and Blacks. The direction of ultrasound needs to be exactly opposite the direction of blood flow for the maximum positive Doppler shift. And it is operator dependent. With a little practice, though, the sonographer needs to correct to the lowest angle, which is determined by the highest pitch and therefore the highest velocity. This is a slide from the American Heart Association, which demonstrates the circle of Willis is intact here, but has several anomalies. Depending upon what paper you may reference, according to the American Heart Association, we have an intact circle about 29% of the time. But this is an article from Turkey published in 2013, which looked at 50 adult brains. And it demonstrated that about 52% showed anomalies. Hypoplasia was the most frequent and was found in about 24% of the brains, with the most common being PCOM, ACOM, and fetal PCA. Now, I'll explain to you what fetal PCA means. This is an image of an MRA, a coronal slice, meaning we're looking straight down from the top of the head. Here are the right brain and left brain, right and left. And here we see the bilateral vertebral arteries joining to form the basilar. Continuing up branches the posterior cerebral artery, but if you notice on the right side, it's missing. What we see is the PCOM is filling the P2 segment, and that's the definition of a fetal PCA. Tortuosity can be very problematic. It results in low velocities. You certainly can't get a good angle of instination. So before you begin your exam, explain the test to your patient. Tell them how long the exam's going to take. Tell them that you're going to use some cold gel and they're going to hear their heartbeat. Record their heart rate, blood pressure, and hematocrit. And if you're in an intensive care unit, you may have PaCO2, intracranial pressure, and cerebral perfusion pressure available for your charting. All of these values will affect your exam. It's so important to obtain an accurate history. And if possible, review imaging studies such as a carotid duplex, CTA, MRA, or angiogram. Be sure your patient is comfortable. And get yourself comfortable. Use enough gel on the probe. Follow the ALARA principle, which is as low as reasonably achievable. Steady your hand. Now you place a big glob of gel on that probe, and it's going to be slippery. So you really do need to steady your hand. Otherwise, you're just going to slide right off the window. You won't be able to instinate the vessel, or you may misidentify the vessel. Always begin your exam on the same side every time. Always perform your exam systematically so you don't forget a vessel. And if you're doing a child, reduce the power to at least 50% and probably even less. So here's an example of the transtemporal approach. You place the probe above the zygomatic arch and just at the hairline. However, the transtemporal window can go as far above to the eyebrow and just above the ear. When you place the probe on the temporal bone, place it at a slight angle and not completely flat. Use a 6 to 8 millimeter sample volume, and be careful, if you use a larger sample volume, you could begin getting other vessels. Begin at a depth of 50, and here is an example. Again, right middle cerebral artery at a depth of 50, normally directed with flow above baseline. And the criteria for determining the middle cerebral artery is being able to trace it from 30 to 60 millimeters. Sometimes in a larger gentleman, you may have to trace it from 40 to 64 millimeters. Use slight movements. To instinate the distal MCA, you usually need to angle superiorly because the M2 segments will curve upwards, but not always. You need to adjust your probe and your angle as you instinate that MCA proximally because remember, vessels are not straight. However, if you find yourself looking and angling every time you increase your depth, then you may be instigating collaterals from a chronic MCA occlusion. At around 54 millimeters, sometimes you see a signal below baseline while you're instigating your MCA. And this can be the anterior temporal branch, which is a little large in some patients, but it's usually not traceable. If you can't find the MCA, just use a different window. Open your sample volume and or increase your power. What I like to do is just go to the contralateral side and see how quickly I can get that MCA. Because if I can get it right away, then what I'm thinking is there could be an MCA occlusion or even a high-grade stenosis. Now, to insonate the ACA, just continue to trace the MCA proximally until you see the bifurcation. Angle superiorly and trace about 10 millimeters. This is an example of an MCA-ACA bifurcation. MCA, again, flow coming towards the probe or above baseline. ACA, normally directed flow going away from the probe or below baseline. And we can insonate the ACA between a depth of 60 and 80 millimeters. The ACA can be absent or hypoplastic. And hypoplastic can mean from anything from being completely absent to just being slightly smaller than the contralateral side. So if you can't find the bifurcation and you still have flow above baseline at depths of, say, like 60, 64, 70, that could mean that the ACA has reversed to collateralize the MCA due to a hemodynamic stenosis or occlusion proximally. So to insonate the terminal ICA, return to your MCA-ACA bifurcation and just angle inferiorly. It usually has a lower velocity due to angle. We can insonate the terminal at depths of 55 to 65, and here's just an example of a flow in the terminal ICA, which again is going to be above baseline or flow towards the probe. If you have the availability of transcranial imaging, sometimes you'll see retrograde flow in the TICA, but that's only with imaging. Remember, the circle fits around your thumbnail, so the vessels are very close together. If you think you're insonating the terminal ICA, you actually could be on the proximal MCA because the MCA is branching from the terminal ICA. There is a possibility you could be on the PCA. So you may want to check your vessel identification. You can do that by oscillating at the atlas loop, or just ask your patient to open and close their eyes. If you're on the terminal ICA or maybe the proximal MCA, if your patient closes their eyes, flow velocity will not change. So for the PCA, again, from the MCA-ACA bifurcation, angle posteriorly. We can insonate the P1 and the P2 segments, and here is an example of P1. Flow is normally directed above baseline, or flow is towards the probe. P2 is normally directed below baseline, or flow away from the probe. The PCOM will divide P1 from P2. And keep in mind that P1 could be fetal, and you may not be able to find it. We insonate the PCAs between depths of 60 and 80. If you're having some trouble insonating the P2 segment, you can see how you may need to just adjust your depth to about 60, 62. Another way to determine the PCAs is, again, to ask your patient to open and close their eyes. Once they close their eyes, you should see an immediate drop in flow velocity, and when they open, it returns to baseline. That's because the PCAs feed the visual cortex. And this is an example of oscillations at the atlas loop. And you can see those oscillatory waves. And sometimes we can pick up the vein of Rosenthal as demonstrated in this waveform. And it's this red line at the base. You can see it and hear it. You can sometimes pick that up in the PCA, the P1 segment as well. And keep in mind that the P1 segment is a branch off of the basilar, and you could insonate the distal basilar. So if you find pathology in your P1 segment, such as a vasospasm, you may want to also say, like, P1 vasospasm versus distal basilar artery. And TCD is not sensitive for picking up a fetal PCA. So if you've lost your place, just go back to 50 and relocate the MCA. And just watch how you're angling the probe and where you're placing it. And that's going to depend upon what window you're using. If you're using a window that's kind of high up by the eyebrow, then you're going to have to angle inferiorly. And again, if you're above the ear, and you need to angle forward or towards the eye. Speaking of transorbital approach, we can insonate the ophthalmic and the siphon. Have your patient close both eyes, and contact lenses are usually not a problem. You use 20% of the power over the transorbital approach. We begin at 50 for the ophthalmic artery, and here's an example of the ophthalmic, normal directed above baseline. You can see that it has a lower velocity and low diastolic flow when compared to the intracranial vessels. To insonate the siphon, increase your depth and slightly tilt the probe laterally. And here's an example of the cavernous portion above baseline and the supraclinoid below baseline. Now, you may not always get both the cavernous and the supraclinoid ICA. And if you go to a depth of about 80 on a patient, or maybe 74, and you angle all the way lateral, you can pick up the contralateral ACA, so you have to be careful. So if you can't find the ophthalmic, what I really do recommend is just go to a depth of 60 or 70 and locate the siphon. Because as you can see in this diagram, there are these ciliary arteries right behind the eye. And if you bring your depth shallower, you may pick up one of these arteries, which you can see they look a little tortuous, and you may misidentify the ophthalmic for the ciliary artery and possibly even being reversed. And the ophthalmic can reverse to collateralize. This is an example of a reversed right ophthalmic, and as you can see, it has a lot more diastolic flow when compared to the left ophthalmic. Behind the neck is the transoccipital approach, and we insonate the posterior circulation through the foramen magnum. We begin at the hairline and below the bone. I like to start at the extracranial vertebral at a depth of 50 at the atlas loop. And this is just an example where we see, now this has flow velocity below baseline, but because it's a loop, you can also have flow above baseline. We trace the vertebral intracranially until about 80 millimeters. And here's an example of 60 and 70. But as you can see, there's flow above baseline. And this is that posterior inferior cerebellar artery that we sometimes see, but again, it's not traceable because as you go distal, it's kind of fading out. The normal direction of flow for the vertebral is away from the probe or below baseline. Now, vertebrals can be hypoplastic or small. They can also end in pica, and I'll explain that in the next slide. They can be hesitant, they can alternate, and they can reverse to collateralize. Here's an example of a hesitant signal, which shows that systole is not filling because it's being pulled back down the vessel, if you will, because of a pressure gradient. This is an example of an alternating vertebral artery. Again, there's a higher pressure gradient, so now systole is now above baseline. we see this hesitant and alternating signals in what's called an incomplete subclavian steal. We can also see these type of signals in a proximal vertebral stenosis or even a small hypoplastic vessel. When we do see these hesitant and alternating signals, we always check the bilateral blood pressures, and if there is a 20 millimeter of mercury gradient between systolic pressure, then we're suspicious for 50% subclavian stenosis or subclavian steal syndrome. Here's an example of a completely reverse left vertebral artery that, if it's reversed intracranially as well as extracranially, that would mean a completed subclavian steal syndrome. You can still pick up a reversed intracranial vertebral, and it could mean that the proximal vertebral is occluded because now this vertebral has reversed to fill the posterior inferior cerebellar artery. You may not be able to trace the vertebrals directly into the basilar because they are tortuous. And as you trace the verts into the basilar, they're joining, so that can be kind of tricky to differentiate right from left. And this is a slide that I wanted to show you what a vertebral ending in the posterior inferior cerebellar artery. And this is taken from the same patient. Here is a right vertebral injection. This is the atlas loop, vertebral artery coming up to join the basilar. And this actually does show the right posterior cerebral artery and a missing left posterior cerebral artery or fetal origin. Here is an injection of the left vertebral, atlas loop, intracranial vertebral, but we don't see is the opacification of the basilar artery. And that's what it means for a vertebral to end in the pica. For the basilar artery, it's typically 80 millimeters is the proximal basilar. We usually go by the depth because, again, this area of the confluence of the vertebral basilar junction is not always detected by TCD. We trace the basilar until it's no longer incunated, and it's a pretty long artery. It's about 32 millimeters in length. When you place the probe on the back of the neck, we angle towards the bridge of the nose. Flow direction is below baseline or away from the probe. If you can't find the basilar, you can have your patient turn up on their side if they're able. Ask them to put their chin to their chest. Or if they can't turn, place a rolled towel underneath their head. Now, if you're doing a patient in intensive care and they have a ventriculostomy, you need to check with the nurse first before you move your patient because that drain is calibrated. What I usually try, though, is just go to the contralateral vertebral because a lot of times it's just an angle of inclination issue. Under the chin, we can, it is the submandibular approach, and we instinate the extracranial ICA. As you can see, we're holding that probe kind of straight underneath, and we want to aim straight down the lumen of that internal carotid. You don't want to put a 60-degree angle to it. And so you place the probe under the chin at the angle of the jaw, flows away from the probe or below baseline, and we use this velocity to calculate the Lindegaard index, or which is what we use for interpreting our exam. If you're not sure it's the extracranial ICA, perform a temporal tap on the superficial temporal artery. And again, If you're on the external carotid, then you will see oscillations. Sometimes sutures, dressings, and central lines can get in the way. You may have to peel down some tape. And sometimes patients have what's called a sensitive sinus, where if you put light pressure on the carotid artery on the sinus, their heart rate will decrease. Within my 20-some-odd years of experience, unfortunately, I did have one patient go asystole, but as soon as I let off the pressure on his neck, he came back. So you need to keep one eye on your patient. Pay attention to side-to-side differences. Here's an example of a right MCA and a left MCA, both at a depth of 50. Both have normal velocities, however, they are a little asymmetric. But what we see here in the right MCA is a slowed systolic upstroke and a blunted waveform. So waveform morphology is very important. This immediately tells me that there is a proximal hemodynamic lesion. Now, bifurcation depths need to be the same. There could be, again, a hemodynamically significant lesion that would cause the ACA to reverse. So as I alluded to in the other slide, if you're still getting ACA flow towards the probe, again, it could mean that it's a collateral. Know what's going on with your patient. If your patient has swelling on one side, if they've had an injury, that's going to change your depths as well. They could have what's called a midline shift. Again, intracranially, that could change your depths as well. At the end of your exam, you should know what you're going to say in your report. If you're not sure and you have the availability, image your patient. Become familiar with CTAs, MRAs, and angiograms. So we feel that transcranial Doppler will certainly add additional information. It gives us velocity information, it gives us directionality, and it's very good for detecting and monitoring of vasospasm. We use it to quantify intracranial stenosis and as well as follow-up exams. If your patient has an elevated creatinine level, or maybe they just don't fit into the scanner, then a TCD may be helpful to give the physician some information about what's going on inside their head and know the limitations of the exam. This is an example of a CTA where a patient had a large aneurysm that was coiled, and you can see the coil artifact obscuring the intracranial vessels. They were not able to comment on those vessels. However, the TCD was very useful and was able to give the physicians the information they needed. Thank you very much.
Thank you. Smile. Well, thank you, Ann. This is very, very helpful, and I know that we'll be having some questions on some of your thoughts there. If you have not sent in questions, please feel free to do that now. I'm going to take just a minute or two for you to send in your questions, and then we'll ask Ann some of what comes in there. Okay, Ann, here's the first question. It says, what exactly are you wanting to document when you say that you need to obtain an accurate history prior to the exam?
So when you want to know, if your patient came in with a stroke, you want to know where the stroke is intracranially, so that if the patient has, if you're going to be doing like emboli monitoring, you want to be able to perform emboli monitoring on the correct vessel. If you're looking for arteriosclerosis due to a stroke, then you're zooming in on possibly a stenosis. So that's the term you're going to use in your exam, in your report, because TCD cannot differentiate between vasospasm and stenosis. It's only by the clinical presentation of the patient. Does that answer your question?
I think it does, Ann. Thank you very much. This is from Duke. What criterion do you use for vasculitis? Is it similar to vasospasm or native intracranial stenosis? Do you do vasculitis in your institution, Ann?
Yes, we do see patients with vasculitis, and we are looking for vasospasm, so we use vasospasm criteria.
Thank you very much. Let's see. If I have flow in both directions at a depth of 48 in an adult, could this be my MCA-ACA bifurcation?
Probably at a depth of 48 in a normal adult, you're seeing the M2 branches, and you may have an overlap of some of the branches, because sometimes, in rare occasions, the MCA will trifurcate instead of bifurcate. So you're probably just picking up another branch. And if it's below baseline, that's probably the inferior branch.
Thank you. This is okay. Wow. Normal velocities in children, do you have a resource table? I think, Ann, I can probably send that out to this customer.
Sure.
Just
I know, but that's up to you.
Oh, well, go ahead.
It's BODE, B-O-D-E.
So she could just go in and
Google, yeah, and then find the article on kids, normal values for children. That's who we use.
Excellent, excellent. Here's another one. I know that the ophthalmic artery waveform should be high resistance and low flow, but on occasion I've seen waveforms from the transorbital approach at depths of 50 to 55 where I have high flows. They look just like an MCA and a low PI. Have you ever seen anything like that?
Well, the sample volume that we use for transcranial Doppler is pretty wide. So you're probably picking up the internal at a shallower depth than what is published, if you will. And that's probably just due to your wide sample volume.
Very good. Another question from the same person about normal velocities. Does the VODA article consider age of the child?
Yes. Yes.
Yes, it does. Okay. At this point, that is all of our questions. So, Ann, we thank you so much. I really think this was very, very much appreciated. I hope that all of you enjoyed this excellent presentation by Ann. Another question that frequently arises is whether these webinars are recorded. Our past webinars are available on the Natus Neurology YouTube channel. Please note, though, that you cannot receive CMEs for watching these replays. They're for reference only. So if you've had a coworker today that was unable to attend, they can go into the Natus YouTube channel and hear this webinar. It usually takes a week or two for it to be posted. Subscribe to our channel and you will receive an email notification every time we add a new webinar. You can find us by searching Natus Neurology on YouTube. So that ends our session today. Thank you for your time and your interest in Natus TCD, and we look forward to having you join us this summer for our next TCD webinar. Thank you.